Hello, my friends. Hold on one sec here. I just got to get myself all together. All right, where is my Facebook? There we go. I think we are live. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, January 11th, 2026, and it is time for another live IC support group meeting. Now, I do realize that this is a big football day, and people might be watching the football games, and that's okay. Hello, Ann. You know, we get several hundred people end up watching these meetings. And I'm going to say most of them watch after we do the meeting, and that's okay. That's okay. Hello, YouTube. I am streaming on two locations right now. I am streaming on YouTube and I am streaming on Facebook as I normally do. My goal in doing these meetings is to help patients who are struggling with pelvic pain find answers, to find possible new treatments, to help understand why this is happening in the first place, because isn't that the biggest challenge of all, is here you are, genuinely suffering in pain. You are genuinely suffering in pain. The doctors might say you've got a chronic condition. My doctor said you always live with pain. You need to get used to it. And we are here to prove them wrong. IC is not all in your head. IC is not your fault. You have done nothing wrong. You should be carrying absolutely no shame or no blame for the fact that, yes, you have pain. And the hardest part is, God darn it would be so much easier if it were shoulder pain, wouldn't it? You could just say it's shoulder pain. But when it's pain down below the waist, oh, it's so hard. So uncomfortable. It's so difficult to describe, especially to people who've never had this pain before. And then, of course, you've got those people who think they know more than you, who have no idea. And those are the ones who are going to say, oh, just drink cranberry juice. And of course, we know cranberry juice is actually quite devastating to anybody with a bladder wall injury who might have an active and like a viral infection or a fungal infection. Yes, there's a little bit of research that shows that cranberry can help prevent or flush out E. coli from the bladder. But here's the thing, interstitial cystitis is normally not bacterial. Interstitial cystitis is actually neuromuscular in origin for the great majority of us, that our bladder is being victimized by a problem with nerves and or muscles as compared to a direct problem with the bladder wall, or nerves and muscles have affected and damaged the bladder wall to some degree. So anyway, my job is not to give you medical advice. I do not give medical advice. My job is to educate you, inform you, try to open up some new doors, open up some new windows, give you a new set of questions that you can ask your doctors, because I don't want you to give up. Listen, it's a new year. I don't know about you, man, but I am so happy that last year was over, although I will say that this is not a promising start to our new year from a society standpoint, but we're talking about IC today, and that's what we're going to do. So one of the things that happened with the government shutdown last fall is we did not get the latest IC research. Where I go to learn about the latest is PubMed, the National Library of Medicine. The National Library of Medicine is an archive of every medical paper published anywhere. It is a wonderful searchable database where you can find anything. And, we all have to understand the last place you should be going for information on a health condition is to TikTok and to social media. You've got to have high quality information to base your medical decisions on. I'll tell you, several years ago, now granted, understand that I'm a wee bit on the older side. I'm like the fairy godmother of the IC world because I built the very first IC website. I ran the very first online support group. I personally have worked with hundreds of thousands of patients in the last 30 years. And when Facebook came along, it was like, there was a part of me that was a little offended. It's like, stay here. Come on. I've got a team of 20 support group leaders. We were rated, we received the same award the National Cancer Institute did in the first couple of years after we got started for the quality of information, the quality of service we provided. And so, Facebook came along, people could create groups, and people started creating IC groups, and that was fine. In the end, that was fine. One of the reasons why that was fine is because I was, after 20 years, getting a little tired of answering the same question over and over again. There are millions of IC patients. I know that I can't support all of them. I say the more groups we have, the better. The more groups we have at this point in time, the better. Because I'm not going to be here. I mean, you might get another 10 years out of me, and that's it. Right? We got to foster that new generation. We got to create new resources. But here's the problem with social media in general is that the group leaders really are not well trained. Or they come in with very, very specific biases. And patients come into social media and they think, gee, that person can tell me what to do. And I distinctly remember, like in the first year of Facebook, somebody went onto a Facebook group and said, should I have my bladder removed? And she legitimately thought people online who had no knowledge of her health should tell her what to do. And I still to this day get lots and lots of emails from people asking me to go into different groups and to make postings and correct things and things like that, which I don't do. I want every group to have their own independence, but I have a lot of fingers in the pie, so to speak. And in the end, I reached out to her privately and gave her a lot more context so that she could make that decision, not based upon social media. Like there were people online telling her to drink green smoothies, and there were people online telling her to do all sorts of crazy things. And it's like, no, we have to understand your anatomy. We have to understand why your doctor is giving you this choice. We have to understand how you've responded to other therapies. Bladder removal is very rarely done. And it's only done, it's really today, if you look at our national guidelines, it's only done in patients who have a tiny, tiny bladder, usually because they have Hunner's lesions that has not responded to therapy. That's the context for bladder removal in 2026. And so anyway, our goal here is to get the quality of information up. And one of the ways you can do that is by using the National Library of Medicine, pubmed.gov. You want to know what's happening in the IC world, just go to pubmed.gov, search for interstitial cystitis. You will find every relevant paper that has been published. Now, interestingly, during the government shutdown, as I said earlier, we didn't get any updates, and that sucked. Now they are flowing in, and well, my friends, we have the biggest update I have seen in a couple of years, and I wanted to go through some of these studies. Now, listen, for those of you on YouTube, YouTube is always prone to sound errors. You let me know how your sound is. And for those of you on Facebook, hello, Ann. Thank you, Ann. Hello, Kayleen girl. I hope you're doing well. I am here as long as you have questions. Normally when I do these meetings, I usually do like a 30 minute little educational thing, and then we just dive into questions, but you are welcome to ask questions anytime. I encourage you to be a squeaky wheel, please. If I miss a question, don't take it personally. That just means that I didn't see it. And that's because the questions tend to scroll. Lisa says, thank you for everything that you do to support us. Oh, thank you, Lisa. And thank you for the 50 stars. Much appreciated. All right. So let's go through a couple of these studies. Now, they're very, very academic studies, and so I'm not going to overwhelm you with the science. I'm just going to summarize it. The first study comes out of China. And I'm going to read the title. Pilot proteomic analysis of urinary extracellular vesicles supports the toxic urine hypothesis as a vicious cycle in refractory IC pathogenesis. Okay, now basically what this means, and if you actually go and read the study and you've got your dictionary up so that you can look up different words, is that we have an injured bladder wall that urine is going into. And as urine enters that injured bladder wall, it creates inflammation. Mast cells release histamine, nerves get very irritated, they release substance P, and basically what happens is that patients get stuck in this vicious cycle of inflammation. Got a wound in your bladder, urine goes in the bladder, mast cells release histamine, that causes redness and inflammation, nerves get irritated, nerves release substance P, that damages the tissue even more. Now we have a bigger wound and yada, yada, yada. We're stuck in this really vicious cycle. So this study is no surprise to me. I don't believe that they're saying that our urine is toxic in it to any great degree. Nobody's ever seen that before. Lots and lots of studies have been done on our urinary biome. And in fact, there's another urinary biome study that was just released that shows that our biome is pretty normal. It's really just the challenge of what happens when you have a wound that's persistently bathed by urine. Okay, so not a big deal. We have a study on the safety of low-intensity shockwave therapy for the lower urinary tract symptoms, including IC and prostatitis, that showed some success. Not widespread, but there were LUTS patients, lower urinary tract syndrome patients, there were prostate patients, there were IC patients. IC patients showed a little bit of improvement. Here's the study that I think is really, really interesting. We have yet another research team, this one from China, that was exploring the role of cannabinoids, cannabidiol, instillations. Now, this is not the first time. There were researchers back at the University of, I think, Michigan 20 years ago who were exploring the role of doing essentially medical marijuana bladder installation to see if that would be helpful. And because medical marijuana and CBD is a significant hot potato in the United States. Yes, it's legal in some states, but it's not legal in other states. The American research community has, for the most part, not funded urology / IC CBD studies. China, however, has. And this new study is very, very encouraging. And let me just read this to you. This study explored the anti-inflammatory and analgesic, in other words, pain reduction, mechanisms of intravesical CBD on a damaged bladder. Specifically, this was a rat study. And I feel really sorry for the rats that they're doing this on. But because, that's why I gave up my career in drug development, because I don't believe in aggressive animal research, but it is what it is. How do they mimic IC? How do they mimic a damaged bladder? Well, they deliberately damage the bladder with caustic medicine in various animals that they're studying. So this is sadly one of those studies, but it is an important study. So what they did is they... how many rats were in there? They have 4 different groups. They had a plain group with a damaged bladder. They had one group that got 10 milligrams of CBD, another group that got 100 milligrams of CBD. They induced bladder wall damage. Then pain sensitivity and bladder function were tested. Here are the results. CBD improved bladder function, reducing instability and prolonging intracontractile intervals in the smooth muscle of the bladder and enhancing smooth muscle contraction pressure. The CBD 100 milligram group showed greater pain relief, compared with other groups. Histology, when they looked at the bladder, showed reduced inflammation, reduced mast cell infiltration, and reduced fibrosis in bladder tissues. CBD, it decreased specific inflammatory markers like TNF and ILF and TRPV levels, and it inhibited some of the damaging pathways. CBD suppressed epithelial injury and downregulated some of those inflammatory pathways, and downregulated some of the cell damaging effects that can occur. So they conclude intravesical CBD alleviates bladder inflammation, reduces neuropathic pain, improves cell growth, etc. So we did a study years ago of patients who have tried CBD. And I could pull up the study on this computer. We could look at it. I think that if I remember correctly, close to 1,000 patients have participated in that survey so far. And our question was, do you use CBD and how does it help your symptoms? And globally, CBD was quite helpful for patients who are participating in our survey. We asked them what form of CBD, do they vape it, do they smoke it, do they do an edible? Most preferred edibles. Some did hemp, some did medical marijuana. Hemp CBD is legal in every single state, although I think the current administration is trying to block that. But you can get hemp at Walmart or Target, hemp CBD. If medical marijuana is available in your state, that is certainly an option that you could explore. Please understand that this is an animal study. This is not a human study. We just do not have a system that is supportive of research involving medical marijuana at this point in time here in the United States. But not the first bladder installation study. Again, the first one was done, I think, at the University of Michigan about 20 years ago. They just couldn't get the funding for it. It was a political hot potato, and they couldn't continue it. So I'm really, really happy. This was published in the World's Journal of Men's Health last October. I'm really, really happy to see that study. Because in the end, some patients are truly, genuinely suffering. I was working with a patient earlier today because I tend to work 7 days a week sometimes. And when you're suffering, it's very important that we have to understand the anatomy, what's driving the pain in the first place, and then make a decision based upon what's driving the pain, AKA your phenotype. And so for patients who have a genuine bladder wall issue, we're dealing with Hunner's lesions, Hunner's ulcers, also known as Hunner's ulcers, or if you are a genitourinary syndrome of menopause patient, or if you're an autoimmune patient where we know we've got some bladder wall integrity issues, CBD is really something that might be worth exploring. Now, if you decide that you want to try CBD, I've got some really strong opinions about that. That if it's legal in your state and you go down to a shop that's selling it, you do not just take the recommendation of whoever's selling it. Never good enough. Do not assume that they know about IC. They don't. You've got to do a little bit of research ahead of time. What you've got to do is you've got to look at the brand names, bring your phone, and then look to see if they have tested the purity of it. Because a lot of medical marijuana, and just like a lot of medical marijuana, is contaminated with pesticides, quite damaging pesticides. There was a pain patient down in Southern California who, legitimate pain patient, had pain from, I don't remember, it was a major injury of some type. He had used CBD quite successfully for several years. And then all of a sudden, he started feeling like there was something very off with it. And so because he, was educated and informed and he might've been in medicine, I'm not sure what his background was, he sent it off to be tested. And it turned out it was massively contaminated with pesticides. So he called a local media outlet, local television station, consumer reporter, and said, hey, this just happened to me. And I think that this is a story, the quality of medical marijuana in our local shops. The TV station jumped on it. They bought a bunch of medical marijuana from lots of different shops across Southern California. They had them all tested, and the pesticide contamination was widespread across brands, expensive brands, cheap brands, organic brands, non-organic brands. Pesticide contamination was a stunningly high. And so, I mean, this was probably 10 years ago. So today, a credible company says that they test it for quality and they publish the testing results. So if you see something that you like an edible, bring your phone and search for it, go to their website, and let's see if they're providing full information to make sure that the product that you're buying is safe. Okay. All right. Now, you guys, it's a week 6 since the super flu for me. Still coughing, although it's definitely better. So, but bear with me. We'll have to stop. My throat is not quite back to normal yet. Okay, let's go back to this new research. So we have a new urobiome study, which is just, they didn't really find anything. So I'm not really impressed with that. Although where it came from was interesting because it came from Pakistan. We have a new study from China on using a nerve pulse radio frequency to reduce perineal pain and pudendal nerve pain. That actually showed some pretty good success. We're starting to see more of that here in the United States. I'm going to try to dive into that and try to do an article on that. I don't really know a lot about that right now. But here's another heartbreaking paper. This is a case study of a gentleman, an 86-year-old man who diagnosed with interstitial cystitis, was on Elmiron for 26 years. 26 years. And he's got retinal atrophy in both eyes. You have to assume that he is functionally, legally blind at this point in time. And so fundus examination revealed widespread retinal degeneration and retinal atrophy in a radial distribution around the optic nerves. They did genetic testing, and that he had no genetic conditions that would explain why he had all this retinal issue. The only variant that they found was an unrelated gene. But what the patient did have is a diagnosis of interstitial cystitis and extensive use of Elmiron for 26 years. And here's the thing that really broke my heart. The patient had a history of excessive coffee consumption. Excessive, I mean, you know that it's bad if they mention that in a medical journal. The patient had a history of excessive coffee consumption. And that immediately makes me wonder if the persistent damage from the coffee was exacerbating his urinary symptoms, which then pushed him to use Elmiron. Cause versus effect, cause versus symptom versus treatment. So here's a gentleman who's drinking excessive amounts of coffee for many, many years, who eventually develops urinary symptoms, eventually diagnosed with interstitial cystitis, still drinking the coffee, still having urinary symptoms. Apparently, well, I don't know. We don't have a big history here. We would hope at some point in time that one doctor would say, hey, maybe you need to cut back on the coffee. Maybe your bladder won't be so irritated. Who knows? And then to compensate for that, he took Elmeron. Heartbreaking, because if he had stopped the coffee in the first year, he might not have needed all that Elmeron, and he might not have developed eye issues. I mean, we don't know. There's a lot of missing information here, but I mean, this is like the perfect, how do I want to say this? A diagnosis of IC and a diagnosis of bladder sensitivity is a bit of a reckoning. It's a reckoning, again, because when you have a wound in your bladder, what you eat directly influences that wound. And if you want that wound to heal, you don't pour acid on it every day. If you pour acid on it every day, is that wound ever going to heal? And the answer is, of course not. That's why patients who drink 1 cup of coffee a day usually don't get better. They usually get worse because there's no treatment that can counteract the damage of that 1 cup of coffee a day. And we know that the bladder is the slowest healing organ in the body. It takes 2 weeks for 1 cell to be replaced. I attended a National Institutes of Health course on bladder healing taught by Dr. Anthony Schaefer 20 years ago. And he very specifically talked about how the bladder wall repairs itself. The bladder wall has the largest single cells in the human body. These are giant cells. We call them umbrella cells, and they have what we call tight junctions. They're very tight, so nothing can get through them. Unfortunately, when one of these cells is damaged, fortunately, when one of these cells is damaged, the human body is always wired to repair itself. Underneath that cell is a little tiny stem cell. And once that surface urothelial cell is damaged, the stem cell gets triggered. It takes 2 weeks for this little tiny cell to grow and fit in where that original cell was. Okay? But while that stem cell is growing to fill in this hole, it is exquisitely vulnerable to acid. Dr. Schaefer said, literally, acid will destroy an entire generation of cells. That 1 cup of coffee a day will prevent these tissues from repairing because you are damaging the new cells that are trying to repair the bladder wall. And I remember I was sitting with some other of the international IC patient groups, and he was talking about all this, and we were all looking at each other going, yeah, we knew that. I mean, we knew that. We knew that the patients who suffer the most are the patients who were continuing to drink coffee every day if you were in that bladder wall phenotype. I am getting many, many phone calls now. When I say many, sometimes even one a day, of new patients who are diagnosed with retinal disease or inflammatory bowel disease who they heard about the whole issue with Elmeron, but they didn't pay attention to it, or they were just hoping it wouldn't apply to them. And then they finally got diagnosed with the eye damage, and they're now wondering what they can do. I will tell you that I was working with one patient this week, and we actually went into the PACER database. The PACER database is a public front of federal lawsuits where you can see all the filings in the cases, you can see the attorneys in the cases, and you can see money that's paid out in the cases. And so far, they have paid out 38, I think, don't quote me on this, but we can look it up. I think it's like 38 million to patients, and then another 3 to 4 million in fees so far. It might be a little bit higher than that. And that tells you that what does that tell you? When a company pays millions and millions of dollars to patients who have been harmed, they're not fighting it anymore, that they see, that they are accepting some association between their treatment and the damage this patient has experienced. So I'm going to do an article on that too in our next magazine. So we've got some new things happening with that. Very, very interesting. Let's go back to this research. And again, for this gentleman who was on it for 26 years, both eyes have severe retinal atrophy. Okay. Let's see. We have another study that, now this one is also kind of a no-brainer. So back, and it's actually kind of directly relevant here to this discussion. 20 years ago, if a patient was diagnosed with interstitial cystitis, the assumption was that we all had an incurable bladder disease, so they gave us bladder therapies, bladder instillations or Elmeron. That was it, right? That was it. But it didn't take a rocket scientist to see that that didn't help most patients. And if you were a patient back then and you came to a support group meeting, it was really clear that patients who were doing bladder therapies and patients who were doing Elmeron still suffered from flares. And the research shows that, I guess the 2015 study showed that Elmeron only helped a placebo group of patients roughly 22%, that the vast majority of patients who tried Elmeron did not improve. So they called that basically a monotherapy, when you give a patient one therapy. And the medical experts, really, they might not have said it aggressively publicly, but they very clearly understood that we needed to do more for these patients than just a bladder therapy. So they started giving a low-dose antidepressant to calm nerves down. They started giving antihistamines to calm mast cells down. Then neuromodulation came around, Botox came around, et cetera, et cetera. So if you look at the literature, we went from monotherapy to multimodal therapy about 15 years ago. That we don't just want to treat one thing, we want to treat kind of the entirety of the patient. We don't want to just make one assumption about what's causing their symptoms, like a bladder wall deficiency. It's like, well, maybe we've got nerves that are irritated. Maybe we've got muscles that are tight. Maybe we need to try to work on those two at the same time. And so this was a study again from China that showed that, yes, that is the correct strategy to do. That if you're just giving a patient a monotherapy, a bladder therapy, the odds are they're probably not going to get that much better. Because again, remember, we now know that 85% of IC patients have tight muscles. So a bladder therapy is not going to help somebody with tight muscles. It might temporarily calm their symptoms, but it doesn't fix the underlying problem. And that's what we have to do. We've got to identify the underlying problem and try to treat that underlying problem. And that is exactly why we do something called phenotyping. And we can talk about that in a bit. And then the last study was a very, I'm going to say, would I consider this a comforting study? Okay. So when my IC symptoms started, and I had bladder pain for the first time at the age of 32, I believed that I was dying of cancer. I mean, that's how severe the pain of IC is. In research studies, IC pain has been rated equivalent to terminal cancer pain on the McGill pain scale. I mean, we knew that 28 years ago. The pain of IC is devastatingly severe, and many patients wonder if they have cancer. And I can remember my doctor at the time, Dr. Mark Klein, who was a fabulous, fabulous doctor. He said, well, you've got interstitial cystitis. And I went, yeah, no, I'm dying. I believe that I'm dying. There's no other reason for me to be in the amount of pain that I am in right now than cancer. I believe you've missed something. And he was like, I don't think so, Jill. I don't believe that you have cancer. And I said, well, I need you to prove it. And I asked for exploratory surgery and actually asked my OBGYN to do the exploratory surgery. And he's like, why? And I said, because I think I'm dying. I think you've missed something. I think I've got a massive tumor somewhere, anywhere. I want you to open me up. And again, he's like, really? And I went, oh, hell yeah. I need you to open me up right now. He's like, okay. And I had my laparotomy in like September, late September of 1993. And understand, I spent that entire summer assuming that I was dying of cancer. Call me stunned when I woke up in the recovery room to his smiling face saying, Jill, you don't have cancer. We found nothing. And in fact, not only did they find nothing, my bladder was perfectly healthy. There was nothing wrong with my bladder. And yet, the pain was so severe, I thought I was dying. Now, I know some of you have had those exact same thoughts. And so I was really glad that I had my laparotomy. I needed that comfort of knowing that I wasn't dying. Okay, so with this latest study, now understand that there is no direct connection between IC and cancer. They have never been able to make a direct correlation between IC and cancer. However, if you are a smoker or you were a smoker, the number one cause of bladder cancer is smoking, because all those carcinogens that you inhale get eventually, they go into your lungs, they get absorbed into your bloodstream. Then they go down to the kidneys and they have to filter through the kidneys. The kidneys try to pull them out. And you end up with urine filled with carcinogens. And that is the number one cause of bladder cancer right there, cigarette smoking. And you know what? Children who live in the homes of smokers can develop all the symptoms of IC from the secondhand exposure. That's how damaging cigarette smoke is. I grew up in the home of a smoker. My mom smoked while she was pregnant with me. It just is what it is. So we have a new study that looked at the role of IC in cancer again. And 863 patients diagnosed with IC. Out of those, it turned out 25% were misdiagnosed with IC and they actually had bladder cancer. So that is a tiny, tiny percentage. And so this is what I would ask you to do. Most of your doctors do something called a urine cytology test at the very first appointment. Man, when they're doing your urine test to see if you have a UTI, they're usually already doing a cytology just to rule it out. So the odds are it's probably already been done. It was probably normal, and there's no worry here. But if you have a lot of blood in your urine, or if you were a smoker, it would be a wise thing to say, hey, doc, can we have a urine cytology just to make sure that there isn't a little hidden bladder cancer going on because I was a smoker? I mean, this is a very, very good study that shows out of almost 900 patients, only 25 had cancer. And understand in Asia where this was, smoking is endemic, massive. So that doesn't surprise me at all. So I'm very comforted by that excellent statistic. However, what have we learned? What have I learned recently as a breast cancer patient? Is the earlier you catch cancer, the easier it is to treat and to save your life. Bladder cancer is, in fact, the easiest form of cancer to treat other than a skin cancer that you can just cut off. Bladder cancer, as long as it hasn't grown deeply into the bladder wall and migrated into the pelvic, into the abdomen, is considered quite easy to treat and cure. So again, if you were a smoker, ask for a urine cytology test. If you got blood in your urine, ask for a urine cytology test. Okay, so here, hold on one sec here. Let me go back here. Mary said, I was just diagnosed with the MCTD mast cell disorder along with all my other things. Does this affect my IC? Is MCTD mast cell? Hold on. I want to make sure I get this right. Let's see. MCTD. Oh, mixed connective tissue disease is a rare autoimmune disorder where the immune system mistakenly attacks the body. Uh-oh. Uh-oh. My Facebook stream just reset. Okay, that's weird. Hold on. Let's see if it comes back. I've got the spinning wheel of doom on my Facebook stream right now. So mixed connective tissue disease is a rare autoimmune disorder where the immune system mistakenly attacked the body, including connective tissues, similar to other connective tissue diseases like lupus, scleroderma, polymyositis, along with symptoms like Raynaud's, joint pain, muscle weakness, skin, lung issues. All right. Is there any connection between that? No. Okay, but hold on a sec. We got to figure out what's happening with Facebook here because now I've got a spinning wheel of doom on it, and I don't know if the stream is working or not. Let's see. I see you guys on YouTube. You're good. I just don't know what's happening on Facebook right now. So, darn. Which means I'm going to lose questions. Let me look at these questions real quick, and then I'll reset it. Okay, so Mary said, Mary, you can see me on Facebook? Can you guys see me and hear me on Facebook? Because I can't see it. But if you put in the chat, you can see me, then I won't reset it. I'll just deal with the spinning wheel of doom. Okay, Anne says Facebook is good. Okay, just a little software glitch. Okay, Hannah says she can hear it. Rebecca says she can hear it. Chelsea can hear it. Sandy says she can hear it too. All right, cool. Let me do this. Okay. Okay, so okie dokie. So we had John. John, you're here. I've been thinking about you, dude, and I want to connect with you and see how you're doing. I'm so glad to see you. Mary said, I have IC, endometriosis, thyroid disease, and mixed connective tissue disease. So, in our phenotyping model, we've got 3 giant phenotypes. We break that down into more, which is 5. And then undoubtedly, as Dr. Christopher Payne said 10 years ago, there are going to be more phenotypes. We just haven't identified them. I do believe that there is an autoimmune phenotype. My guess is it's 2 to 3% of patients have an autoimmune disease affecting their bladder. Why do I say that? Because previous research has found lupus or Sjogren's in roughly 2 to 3% of patients. And so, Mary, you may just be in that autoimmune phenotype. But I would also say to you that let's not jump down that rabbit hole right away. You need a proper phenotyping. We need to know where you are with estrogen atrophy. We need to know the health of your bladder wall. And most importantly, we need to know the role of your muscles and how are your muscles doing, and do you have pelvic floor dysfunction? Because there might not be a connection at all. It could just your IC symptoms could relate entirely to falling on your tailbone. Or I was working with a patient who earlier last week, again, symptoms for several years, diagnosed with pelvic floor dysfunction, did some pelvic floor physical therapy, didn't really stick to it long enough. And as we were talking about that, and I was asking about injury or trauma, well, it turns out that she was a gymnast. She was a gymnast in childhood, and then she switched to cheerleading. And I asked her, I said, all right, how did you do flying splits? And she goes, many. And I went like, and she said, many. And I went, okay, think about what that does to your pelvis. Think about what that does to your pelvic floor. Every time you fell in gymnastics, you were compressing muscles or compressing nerves. God forbid you fall on the balance beam directly on your crotch with one leg on either. So the gymnastics is well known to cause trauma to the pelvic floor. And then gymnastics, I mean, cheerleading, especially flying splits, also well known to cause damage to the pelvic floor. And so as she was wondering, why do I have pelvic floor? It's like, honey, all you had to do is say you were a gymnast, and it's a no-brainer at that point in time. Angela said, or here, hold on. Julius says, my urologist won't put me on Elmeron because of the eye damage. I'm taking Vesicare, vitamin D, and had a few DMSO treatments. I completely agree with your doctor. I think that is absolutely the smartest thing to do. I was working on with a patient a couple of days ago who had been on Elmeron for 20, 25 years, and she was very reluctant to stop it. And I said, well, have you tried anything? And her answer was, well, what her doctor kept saying to her was, there's only one FDA approved medication for IC Elmeron. That's the only thing I can give you. And my answer back to her was, the FDA approval of Elmeron, according to the investigative report that was published last year, shows that it was approved without adequate testing. You know, that the company requested Elmeron to be FDA approved. They applied for that in 1991. The FDA denied it because the research they presented showed that only one doctor had success with it. That happened to be the doctor who helped to invent it and had a financial interest in it. And so the FDA said, no, we're not going to approve it. We believe you need to do more research without the guy with the financial interest to show us that other doctors can use this safely and effectively. Well, the company hemmed and hawed. We don't want to do that. We're just going to give you more data. The company submitted a new application with more data. The FDA again rejected it, basically saying, all your data shows us is that there's only one doctor who can safely use this. Every other doctor who's tried to use it does not get the results. So the FDA rejected it again. The FDA asked for more research. They even had a meeting with the company outlining the way they wanted that research study to be done. And the company apparently balked and reformulated the data again, put in some compassionate use data, which is not a formal study. That's just kind of anecdotal information gathered from patients who were using it before it's FDA approved. And mysteriously, it got approved in 1996. That the FDA did not force the issue. The FDA did not ask for that formal study to be completed. After 5 years, they dropped it, and for some reason, they approved it. I don't understand why they did. What I can tell you is that in 2015, 18 years after it was approved, the Elmeron Clinical Trials Group, I think that's what they called it, led by Dr. Curtis Nickel, did that study that the FDA asked for 18 years after the fact. And guess what? That study showed it didn't work. And they interviewed Curtis Nickel, the leader of that study, the PI in that study, and he thought it'd be pulled from the market. He was, imagine. And the entire point of this big investigative report is that it turns out the FDA has approved a lot of medications without data showing it works. And of course, not only do you need data that shows it works, you need data that shows it's effective and safe. We want to make sure we have a good safety profile here. So I look at the FDA approval of Elmeron now as being quite questionable. If you go to the IC Network website, there's a big article on it that I give a timeline. And again, this big investigative report that was done by a company called The Lever. they were looking for lots of medications that had received FDA approval without a safety and effectiveness testing. I mean, some medications are being approved based on lab testing, like they've never done human trials. I mean, at least in Elmeron, they tested it with humans. They just didn't look at the data in a non-biased way, if that makes sense. So if you go over to the IC Network website, I've got a big article on it with timelines, direct quotes from the FDA letters, from the Freedom of Information Act requests. And so, you know, do I think Elmeron should have ever been approved? No, I don't. At this point in time, with the information that we have right now, I think that they jumped the gun. I think they should have waited for that study. They shouldn't have waited 18 years. They should have waited 2 more years, let another research team do a large study and base it on that. So we can only ask how many people are now going blind because they allowed this medication to be on the market. Oh, there's so much more I could say, but I'm just going to stop it there. You can go read the research right on our website. Angela said, when my doctor tried to put me on Elmeron, I went down a rabbit hole and I did my own research and found it to be more harmful than good. I started taking MSM and glucosamine. I control my diet. I sought out pelvic floor therapy. I have been in remission for over 15 years. Yeah, girl. Yes. And the thing here is, you know, again, now that we know that 85% of IC patients have tight muscles, it makes absolutely no sense to put everybody on a bladder therapy. Because many, if not most of us, have fairly normal bladders. I always had a normal bladder. And the only reason I didn't do Elmeron, now remember, I had a pharmacology degree, so I looked at the FDA approval of Elmeron a little bit differently than other people, because to me, I wanted to know about something called bioavailability. I wanted to know how much of the medication actually arrived in the bladder to be healthy and to be productive and to be therapeutic. And the bioavailability of Elmeron is very poor. It's like one study is done by one of the original research teams found that 92% of Elmeron was destroyed by digestion, never made it to the bladder to do anything. And that's why patients had to take so much of it over time to get a meaningful amount into the bladder for the bladder to do anything. And it just didn't make any sense to me. I mean, if you swallowed a Band-Aid, do you expect it to come out the other end of Band-Aid? And the answer, of course, is no. All right. Mary is a breast cancer survivor too. Yeah, man, I got to tell you, my incisions got so messed up with the flu and just coughing so much. It's like I'm back to my post-op pain a month after surgery. It's so annoying. Christy said, I'm going to have to watch the replay with the wind and the storm here. We're not getting, your internet is not working well. I get it, honey. Hey, we finally have a blue sky out here in California. Here, I got it. I'm hot right now. Hold on a sec. Let me just, a big part of this, of me staying cool, is keeping my hair off of my neck. So let me just, whoops, hold on. All right, I am here when you have questions. Okay, oh, here we go. We got some more questions on YouTube. Hold on a sec. Oh. Crystal said, are there any free and easy exercises for the bladder and pelvic floor that you can do in bed? And the answer is yes. And you know where you can find them is on the IC Network, on the IC Network website. If you go to our pull down menu of IC, go down to the very bottom, there's a link that says free downloads. I have a whole 2 pages of pelvic floor exercises that you could do. The other place that you can find those same exercises is in our flare guide. Whoops, I missed some hair. Hold on. All right. Stay. So our flare guide, and a couple thousand of you have bought this so far. It's great. I'm really glad that it's helping. We talk about pelvic floor flares, and we give you lots of things that you can do. All right, I got a rebel. And then the other guide is our diet guide. The diet guide is at the printer right now. I should have it on Monday or Tuesday, and it will go live for sale on Monday or Tuesday. So this is our updated brand new food list, along with a lot of articles on things like, so what can we eat? So what can we drink when diets conflict? Like if you have IC and IBS and that's a problem. Working your way back to coffee, how to approach eating out, all sorts of really meaningful articles there. So that should be done imminently. I will tell you, it has kicked my you-know-what. Because, in fact, I was working on it yesterday for hours, my PDF version. I created an electronic version with a bunch of links in it because I wanted you to be able to click on links for, hold on, what is that? It's a helicopter flying over really low. So anyway, there's probably 300 links in this PDF file. And when I created, or in my Word file, when I created my PDF, all the links disappeared. And it turns out it's a bug in the Word to PDF process. So the PDF file will be done soon. It's on this computer. I just have to hand re-enter all the links. So it sucks. I'm about 3/4 of the way done. Donna says, what is the best supplement when you have a bladder wall flare? Okay, we have to think about underlying cause versus the effect. So a bladder wall flare is going to occur when the bladder wall has been injured in some way, usually by food, right? So if you're having that coffee, if you've gone out and had really spicy food, if you've had champagne on New Year's Eve, those are things that are going to irritate a vulnerable bladder. So the question is, why is the bladder vulnerable in the first place? It's going to be the most vulnerable in patients with Hunner's lesions. If you've got open wounds in your bladder, alcohol, acid is going to go right into those wounds and irritate those wounds. Okay, so what do? Number one, you got to drink water. We got to dilute that urine to try to dilute the acid. So that's why, if you're going to risk it and you want to have that cup of coffee, you could do pre-leaf to reduce some of that acid and follow it with a big glass of water. The purpose of the water is to dilute the acid. The second thing you can do is alkalinize your urine to remove acid. That's the pre-leaf. So the best supplement, Donna, for a bladder wall flare caused by acidic food is pre-leaf, because that will immediately neutralize the acid, which is irritating your bladder wall. The challenge is now we've got a really irritated bladder wall. And you're up every 15 minutes, you're up every 30 minutes, you're in big time pain. What can we do to temporarily soothe the bladder, to get it through a couple of days while it's trying to calm down and while it's fighting that inflammation? That's where aloe has a place, because aloe is soothing to irritated skin. So, if you have a sunburn, you can put aloe on it and it immediately feels better. So many patients have done aloe to soothe their bladder wall. The challenge is that now that we're phenotyping, the role of aloe, in my opinion, has gotten very, very small. I don't see aloe as a long-term therapy anymore because the bladder is not made of aloe. Aloe is not what I would consider constructive. Aloe is soothing. Aloe is a good way to minimize some of the symptoms. But underneath it all, it's not going to fix tight muscles. It's not going to fix a Hunner's lesion. It's not going to fix estrogen atrophy. So I save aloe now and suggest aloe now for just the week or two after a bladder wall flare, just to try to calm that skin down a little bit. On the IC network, the aloe that we now sell is called Aloe Path. We haven't done straight aloe in several years now. The reason why Aloe Path is, in my opinion, better is because it combines the soothing effect of aloe with the nerve calming effect of PEA, palmitoyl-ethanolamide. So you've got two methods of action in Aloe Path: the soothing effect of the aloe on the irritated skin and the nerve calming effect of the PEA to directly reduce some of that pain and discomfort. So again, pre-leaf to alkalinize the urine, aloe to temporarily calm and soothe the bladder while the bladder's healing from that irritation. But now the other question we have to ask is, what's the underlying problem in the first place? And if we have a compromised bladder wall, say from estrogen atrophy, so, think about the bladder. It's the only organ in the human body designed to hold toxic waste. So how can the bladder hold ammonia for hours at a time and not get damaged? It's a real evolutionary marvel, because it turns out the way the bladder protects itself is with a really thick, robust coating of mucus. Your bladder is like your mouth. It's hollow and slippery on the inside. And that mucus is a really thick barrier. It's hydrophobic. It pushes urine away from the cells. Okay, so again, your bladder, your urethra, your vulva, your vagina, and your mouth are mucous membrane organs or structures. And that mucus is critical to the health of that skin. Here's the underlying problem. It is estrogen driven, estrogen dependent. So when you're young and have a lot of estrogen, you have a lot of mucus. But if you're on estrogen suppression meds, if you're getting older, if you're on birth control, if you're on Lupron, tamoxifen, if you don't have the estrogen, your bladder can't make the mucus anymore, and your bladder's ability to defend itself is now greatly compromised. And so for those patients, what's the correct therapy? Number one, estrogen. This is called the genitourinary syndrome of menopause. So the very first thing that most doctors are going to suggest is using a topical estrogen. You can use it at the urethra when your urethra starts to scream. You can use it at the entrance of your vagina. You can put it inside of your vagina, and the estrogen helps that skin get stronger. But if that's not enough and you're still symptomatic, then we look at the chondroitin-based supplements. That's the bladder builder, the bladder rest, the Cystomand, or the Cystoprotect. Why? Because chondroitin is a building block of the bladder wall. Chondroitin is found in the bladder wall. It is essential to the superficial integrity of the bladder wall. And chondroitin is a treatment for IC in most of the world, just not in the United States. And it acts by coating the bladder, but it's a natural coating. So when we think about long-term use, rather than going for the aloe, which is water soluble, which basically flows out of your bladder very quickly, we would be looking instead at a chondroitin-based supplement. That is my opinion. Sherry said, at 65, us girls still care to get out our hair looking great. Thank you. I don't know. I always wash it before I do these meetings, and you can see the white coming in. That all started 2 years ago. It's very annoying. You compare it to the color of my hair. See, look, that's what my hair looked like 3 years ago. And now it's like that. This whole getting old thing sucks. I just don't understand a lot of it because I feel 25. I do not feel 65. And yet I look at my face and I look at my body and I go, ooh, things are changing. Donna said, how often pre-leaf per day during a flare? How much allopath per day during a flare? You only use pre-leaf before a meal, or if you're trying to alkalinize your urine, and this is not, you don't eat it like candy, eat like 1 or 2 a day. And with allopath, I think it's 1 or 2 a day. Just follow the instructions on the label. You can find it in the IC Network shop. Hannah says, I appreciate that you want to get to the root cause rather than just treat the symptoms. It's hard to receive a diagnosis and then be told there's no cure. Like you, I worried that I had cancer. I know there has to be something underlying this, and I won't stop until I figure what it is for me. Hannah, you should give me a phone call because I ask a lot of really telling questions to try to help identify that. And I'm going to say right now, for the vast majority of patients, it's a trauma. It's a physical trauma that occurred. I mean, so we had a doctor publish a paper about 10 years ago, or maybe 8 years ago, who was looking at IC diagnoses based upon age. And he just flat out said, if your symptoms began as a teenager in your 20s, we're always going to look for injury first. Does this patient have a history of injury or trauma? They've fallen on their tailbone. Were they raped? Were they abused? Were they in a sport which could have traumatized their pelvic floor? Did they have a very difficult childbirth? So for the teenager and the 20-something, we really explore the concept of injury. And then in your 30s and 40s, then we start looking at other things, and we could start looking at infection a little bit more. And, when we think about our phenotypes, that's when we would look at, is there a chance that this patient has a viral infection in their bladder? If you had Epstein-Barr, that Epstein-Barr virus has been found in the bladder, etc. And by the way, we have a new paper that was published on COVID cystitis. And they talk very specifically about the patients who no history of bladder issues until they got COVID. When they got COVID, all of a sudden, they started having urinary frequency and symptoms of IC. Many of them have been diagnosed with IC. We call this a de novo onset. What that means is that there was no history of any urinary symptoms before they got COVID. None. And so this research team was suggesting that this is becoming a larger, more significant public health issue. COVID cystitis, COVID-associated cystitis. And they also talk very specifically about how they have found active virus in the bladder wall in some patients and in the penis in men in some patients. So the COVID virus can spread throughout the entire body. Epstein-Barr can infect the bladder wall. Polyoma can affect the bladder wall. Herpes can infect the bladder wall. HPV can infect anything down there. God forbid you have the really aggressive human papillomaviruses. Christine says, I was put on a 750 milligram antibiotics because I got severe UTI plus bronchitis, and now you're in severe pain that I can't get rid of, so I can't stand this pain any longer. Christine, what's the antibiotic? There are some antibiotics that are really well known for irritating the bladder, like Augmentin. I mean, I did 3 weeks ago, because I had pneumonia from this darn flu, I did a week of amoxicillin, didn't touch the pneumonia. I did 10 days of Augmentin. First time in my life I have ever taken a full period of Augmentin. And I will say my bladder is not quite its normal calm self. Last night I got up, I think 3 times. I went to bed at 10. I got up at midnight. I got up at 2:30, and I got up at 6. Normally, I would get up once a night. But even the Augmentin didn't kill the pneumonia. I ended up back in the emergency room because my sinuses started bleeding, and they put me also on Z-Pak. So I did Augmentin and Z-Pak together. So I hear you about the bladder wall being irritated. Levofloxacin. So call your doctor and say it's irritating the hell out of your bladder and ask if they can switch you to something else like Keflex. You know, I mean, like the first time I took out, when my IC was really, really bad in my 30s, and they gave me Augmentin for something, probably a sinus infection. Man, I took 2 pills and I was on the floor. My bladder was screaming. But, you know, and that's when I just called the doctor and said, listen, I can't take this. This is killing my bladder. And they just switched me over to Keflex and I was fine. So just let them know what you're going through and see if they'll switch it up for you. Donna said with pre-leaf, 1 or 2 tablets a day, once or twice a day, there's a difference. Well, but remember, pre-leaf is about, you know, you normally take pre-leaf at a mealtime when you're going to eat something acidic. So you don't, I mean, the whole point is to prevent the flare in the first place, right? So rather than eating lasagna, waiting for the flare to start, and then taking pre-leaf to alkalinize your urine, you're supposed to take the pre-leaf when you eat the lasagna so it immediately alkalinizes your urine so your bladder doesn't start screaming in the first place. I don't know if that's kind of what you were referring to and what you were saying there, Donna. Liz says, Happy New Year, everybody. Tomorrow I will be 7 months post-op from having a cystectomy and urostomy. My bladder is gone, and so is all the pain I have been suffered with for over 50 years. Praise God. Hallelujah, Liz. I am so happy for you. I tried everything, but the last 2 years, the pain was totally disabling. My IC was totally bladder-centric. I never had an injury, no pelvic floor problems, just an extremely inflamed bladder. I am so happy now. It's so weird to think my abdomen, no pain at all. It feels so calm and peaceful and quiet and just amazing. Oh, Liz, I'm so happy for you, hon. You know, now listen, that is a beast of a surgery. You know that. I mean, I'd love to hear if you could share what your recovery's been like, so you could tell other people that, I mean, this is not an easy decision to make. This is a decision to have a irreversible surgery that has a very long recovery period. But it can be life-changing for some patients, you know? I mean, if you've got a very small shrunken bladder, if you've got Hunner's lesions that have not responded to therapy, then most importantly, in the latest guidelines, they're really distinguishing between bladder-centric versus widespread pain. You know, I mean, if you've got a history of TMJ and fibromyalgia and migraines, along with your IC and your IBS, that tells us that's your central nervous system. That's central nervous system driven. So removing your bladder is not going to stop that. What we have to do instead is calm the central nervous system down. But in her case, she was entirely, in Liz's case, she was entirely bladder-centric. And removing that bladder had a profound improvement. And honey, I am so happy for you. But tell us, how was your recovery? I need to go, speaking of going to the bathroom, let's take what we call a bio break. And what we're going to do is we're going to rate our ability to release urine. Because I'm a pelvic floor patient. So sometimes that's how I know how healthy my pelvic floor is how quickly I can start urination. So give me 30 seconds. I'll be right back. All righty then. So I will tell you, it took a count of 2 for me before I could release urine. Chelsea said, ability to release urine is a 0 because you are catheter dependent. I'm sorry to hear that, hon. Why are you catheter dependent? What's going on with that? Do you have a neurogenic bladder? Or do you have very, very, very tight muscles? What's going on with that? Tell us. If only if you want to. You have a neurogenic bladder. So what is a neurogenic bladder? A neurogenic bladder basically means that the nerves in the bladder either have stopped functioning or are behaving abnormally. Sometimes there can be, I'm not sure of all the causes of neurogenic bladder. Sometimes there's spinal cord injuries. Sometimes it can relate to cerebral palsy or multiple sclerosis. And quite a few times it can relate to injury or trauma. It can even relate to having compressed disc in your back or ruptured disc in your back. Chelsea, I'm really sorry that's going on. How are you doing otherwise, though? Are you struggling with infections from the catheter? Are you catheterizing yourself, or do you have an indwelling catheter? Donna says, I have IC, TMJ, chronic migraines, so much pain all the time. Okay, so Donna, you're in the widespread pain phenotype like me, because I don't consider myself an IC patient because I'm usually symptom free, and I have been for quite some time. But I have a history of IC, I have a history of IBS, I have pretty significant TMJ right now. That's my big problem. I haven't slept in a bed in 5 years because if I lay back, the left side of my jaw starts to dislocate every single time. It's very annoying. I'm very, very frustrated. I miss my bed. I sleep in a recliner at an angle. So it started during COVID. Anyway, that's a whole nother story. If you have a history of migraines, if you have any of the chronic overlapping pain conditions that we now call widespread pain. So widespread pain is being driven by the central nervous system. And we have a absolutely phenomenal research team called the Chronic Pain Research Alliance that was convened, and it's led by the TMJ Association, fabulous group, the TMJ Association. They convened a group of experts to try to understand why this happened. Why do some people like me end up with all these pain conditions and others don't? Another characteristic where we really know the central nervous system is involved is patients develop sensitivities. We tend to have very sensitive skin. We tend to have a wicked sense of smell. We can smell things that other people can't smell, and smells drive us crazy. Those are all signs of a more sensitive nervous system. So they started studying the nerves. We look at the nerves in the skin, like small fiber polyneuropathy, which is another thing that I have, completely controlled by PEA, which is wonderful. They studied the spinal cord, and eventually they started looking at our brain. And that's where they found it. Now, this is going to sound scary. It's not scary at all. It makes total sense. But here's what they found. Patients with widespread pain have a brain that is living in a constant state of fight or flight. The 24 hours a day, 7 days a week, our brain is behaving like our life is at stake. How do they know that? Scans show that the amygdala, which is the command and control center for fight or flight, is on all the time. So what is fight or flight? Fight or flight is how our body protects itself from threats. You go back a million years, and when we were walking around with spears and living in caves, The purpose of fight or flight was to help us respond to a threat. So if we were up on a hill looking down and we saw a saber-tooth tiger walking through the valley, believe me, we went into fight or flight. What does that do? That prepares our body to fight, flee, run, or freeze. There are other things. The way that it does that is it turns off the parasympathetic nervous system, turns on the sympathetic nervous system, which takes command and control of the brain and the amygdala. It raises our heart rate, it raises our blood pressure, it tightens our muscles to prepare us to defend our lives. Now, normally fight or flight is short term. I mean, once a saber-tooth tiger walks over the hill and is gone, there's no threat anymore. Now, for us in 2026, we have a completely different set of threats. For me, for example, it's fires. If I were to smell smoke and see a fire coming down the hillside, that hillside right there where I've had fire come down and almost burned my house down, believe me, if I saw fire, I'm going into fight or flight. But you know what? It's 2026. I can call the fire department. I call the fire department. They come out. They put out the fire. An hour later, the fire's gone. The threat is gone. Fight or flight is supposed to turn off. And normally it turns off. But for us, it doesn't. We're stuck. We call that a central nervous system maladaptation. And you know who taught me the most about this was the International Pelvic Pain Society at a conference a couple years ago. So the question then is, why does the brain do this? Why does the brain do this? Well, what the research shows is that for 80% of the children who grow up to develop widespread pain, there is a major physical injury. So, for example, I was working with one woman in her 50s who, as a teenager, when she was in high school, had a broken back. But her mother didn't believe her and sent her to school for 3 weeks with a severely broken back. It takes 10 days of pain to put the brain into a constant state of fight or flight. And think about kids. Number one, we often don't even tell. I mean, think about a little boy riding around on his Stingray who jams his crotch on the bar of his bicycle and he drops to the ground and he's covering his testicles and he lays there for 10, 15 minutes while things calm down. And then, you know, he goes home. Is he going to tell his mom he was in that accident? No, most of the time they don't. Got to be really severe to tell your mom. Kids hide it all the time. For the other 20%, it's a history of bullying and abuse. And in my case, I have been very open and honest about what happened to me. I grew up in a neighborhood with a kid my age who became a rapist and murderer. I was attacked in 4th grade. Many people, many of my peers were attacked badly. I ran to school as fast as I could. I ran home as fast as I could because I never knew when I was going to get jumped. 10 years. The year I went away to college, he raped and murdered my neighbor. I still remember I was in my dorm room when they called and told me, and I fell to the ground screaming because I knew if I'd been home, that would have been me because I was a favorite target as the redhead. So think about what that did to my brain. Every single day that I went to school, as soon as my mom woke me up, I went into fight or flight. He was a legit threat. He was very violent and aggressive. Mentally ill, obviously. The only time I felt safe was when I was at home. This home I'm in now. And the legacy of that is profound. Because I look at my life and I look at, I've had many opportunities over the year. I was a presidential fellow. I was invited to go teach on an aircraft carrier in Asia when I graduated from college. I didn't do it. I let fear stop me. I was invited to work at the Pentagon as a presidential fellow and at NASA. I said no because I let fear stop me. And I just got to the point where anytime anybody asked me to do anything, I said no. Like I literally, hey, Jill, you want to go to the movies? No. For decades, I did that. I never understood why. Like I legit have had a very lonely life because of this. And even still at the age of 65, I understand it all. I understand it was never my fault. I understand that this is how a child's body adapts to stress. And a common theme in my office when I work with patients, because I realize what happened to me is very unusual, the far more common theme is growing up with an alcoholic parent. I can't tell you the number of patients, many, dozens and dozens and dozens of patients who have shared their story with me that they grew up in a violent home or an unpredictable home with an alcoholic parent or a mentally ill parent. Think about, how does a child's brain respond to persistent threats over time? Because the child doesn't understand what's happening. It's that brain's job to save their life. And that's why fight or flight kicks in. The problem is turning it off. How do we turn it off? Well, we know now how to turn it off. It's actually very, very easy to turn fight or flight off. And going to a good anxiety management class. I took an anxiety management class when I was 35 that completely changed my life, because up to that point, I was having panic attacks fairly consistently, especially going to the doctor. I had a lot of medical anxiety. And got one of the reasons why I went back to grad school and got degrees in psychology was to understand my psychology. And even though I was a straight A student and a presidential fellow, that still did not stop my panic attacks. And finally, one day, it's like, clearly I need help. And I signed up for a class that completely changed my life. And I have not had a single panic attack since the age of 35 when I took this class. And what was amazing about this class, so it was developed by an orthopedic surgeon with anxiety disorder for his son, who also had anxiety disorder. And, Christine said, my mother didn't believe I broke my tailbone. I ended up in the hospital with sepsis. Yeah, girl. Totally. So the really cool thing, I didn't talk about my childhood trauma for 40, maybe 50 years, 45 years. It was too painful. And if we made a really core mistake when I was young, I should have been in therapy when I was young. But back then, therapy was shameful. And I grieved the girl that I could have been if I had had proper therapy to help me understand why my body was doing what it was in the face of this very, very persistent stress and trauma. We just didn't know. I have done therapy since then, and it's something I really have to work on consistently. So anyway, when I signed up for this class, I didn't want to do it, but I knew I needed to do it. And I had a panic attack before the first class because it was at the hospital, and I panicked at the hospital. Okay. So anyway, I get to the class and I actually meet other patients. Like there's like 30 patients in the class, and y'all just circulate and hi, hello, yada, yada. And up to that point, I really thought that I was the poster child for dysfunction. Here, hold on a sec. Somebody's at my door. I'll be right back. Hey, I'm working right now. Yeah, I'm working. Oh, thank you. Okay, no, I'm working. Okay, sorry. Oh, okay. All right. Delivery. Okay, so let's go back to the class. Because I really, really For those of you with widespread pain who have this, I really want to emphasize you did nothing wrong. No shame, no blame. Okay, so I go to this class and I meet other patients. And like before I'd actually ever met other patients, I just felt like I was a poster child for dysfunction. I didn't understand any of it. All I knew is I didn't feel normal. I was panicking all the time. And I truly, truly thought that I was damaged goods, unworthy, and unlovable. I mean, that's in my soul. That's how I felt at the time. I just didn't understand it at all until I met other patients. Because you know what? When I met other patients, oh my God, they were normal, just like me. And when you hear their stories, it's like, you know what? We are all normal people who just had something bad happen to us. That's all. And so immediately I went from feeling abnormal to feeling, you know what? I'm so normal. I just got hurt. We had the winners of the first lottery in the state of California in my class. They had developed anxiety after winning the lottery. I think maybe they were threatened. I don't know. So that was so cool. It's like, oh, that happened to you and that happened to you. Oh my God, that happened to me. Oh, okay. And then the instructor was brilliant. He, like, literally, the first thing he said is, how many of you say no to every invitation? We're all looking at, well, people are like, the whole class raised their hand. We all said no to every invitation. He's like, you know what that is? We're like, no. He goes, that's a guarding response. That's your brain trying to protect you. It's like, whoa. Oh, had no idea. Had no idea. And then he said, and how many of you would consider yourself sensitive? And we're like looking at each other going, yeah, me, me, that's me. Like everybody raised their hand. He goes, you know what that's from? That's because your central nervous system's been working very hard. A central nervous system that's been injured or traumatized becomes sensitive. It's like, though, how many of you have very sensitive skin? Oh, everybody. How many of you are very sensitive to smells? Everybody. How many of you are sensitive to meds? You hate taking medication because you know you're in a side effect. Like, how did you know that? Me too. And again, he's like, that's what happens to a central nervous system that's been through trauma. And I guess, you know, I mean, if you think about it, you think about that child's brain who's hiding in her room, you know, because dad got home and he's going to start drinking. So they're very quiet in their room and they're just listening. They're becoming very sensitive to sound. Their brain is like listening to the very, 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 very first sign that something bad can happen. I think that's, but then there's also adaptation to stress over time and direct injury and all that sort of stuff. Okay. And then he said, so again, how many of you consider yourself very chemically sensitive? And like, and I mean, think about it. If there's ever anything out there that people poo-poo, it's people who say they're chemically sensitive. You know, I mean, we used to, not me, but they used to laugh at people who said they couldn't tolerate perfumes and things like that. Man, that's legit. That's real. That's so real. So he goes, how many of you would consider yourself chemically sensitive? Oh. And he said, you know, so here's the deal. Not only are you sensitive to chemicals on the outside, you're sensitive to chemicals on the inside. And he said, right now, every single one of you is overdosing on adrenaline. You've got so much adrenaline through your body. That's what's driving the panic. That's what's making your heart race. That's what's giving you stomach aches. That's what's making you nauseous. All of that is you have so much adrenaline shooting through your body right now. The secret to controlling anxiety is to control the adrenaline. We have to bring the adrenaline down. When we can bring the adrenaline down over time, that calms the entire central nervous system down. So he taught us a really easy technique that I've used ever since to do that. And so the other part of this trauma thing is that as we get older and as we understand a little bit more about this, our brain has to work extra hard to get our attention. And so somebody says, "Hey, Jill, you want to go to the movies?" My first answer would have been no. A year or two later, if it's continuing, "Hey, Jill, you want to go to the movies?" No, I'll ruin it because I'll have to go to the bathroom. Okay, and so I don't go. A year later, my best friend Sheila says, "Hey, Jill, you want to go to the movies?" No, I have a really bad flare. And then you'll have to leave and drive me home. And like, I literally stopped going. I got to the point where I just didn't ride with anybody. I always drove my car so I could leave whenever I needed to leave because I felt so guilty about having to stop them. So we call this catastrophic thinking. Catastrophic thinking. It's not just, no, it won't be a good movie. It's no, if you go to this movie, you're going to have a catastrophic flare and then you're going to get COVID and then you're going to die. You know, that's a perfect example of a catastrophic thought. So as we get older and we start to be able to think about it, we go, no, that's not going to happen. I'm going to go to the movie. So your brain doubles down and says, no, you can get COVID. Your brain's doing everything it can to get you to stay home where it's safe. And that drives very intense catastrophic thoughts. Or if home was your dangerous place, then you're always going to be, you're going to have the opposite catastrophic thoughts, but they're just catastrophic thoughts. It's just your brain trying to control you and say it's not safe. And you know, we didn't just have one catastrophic thought a day, honey. We had dozens. If you've got anxiety disorder and you've got a history of trauma, I mean, all of my thoughts were negative, scary thoughts, all of them. And I'd gotten so used to it, I just tuned it out. I mean, in my 20s, I was miserable because I was dealing with all this, all the results of all the trauma that I went through. So he said, the way we're going to control this is we're going to bring the adrenaline level down in your bloodstream. And the way we do that is by responding to the negative thoughts that are scaring you. So whenever you have a negative thought, the very first thing you do is just visualize a stop sign. Just stop it. I don't want to hear it. Stop. And then you take a single deep breath. You go in for 4 and out for 4. And that oxygen has now disabled the adrenaline from that negative thought. Because again, when you have a catastrophic thought, you give yourself a jolt of adrenaline. You don't just have one a day, you got like 100 a day. That's a lot of adrenaline floating through there. So we gotta stop that in its tracks. So negative thought, you're going to do a stop sign, then you're going to take a single deep breath, and then you just have to remind yourself, Jill, it's just a thought. It has no power. It's just a thought. It's just your brain guarding you. That's all. Okay. Stop sign, deep breath, minimize the thought. He said, okay, we just have one goal here. All we want to do is bring your adrenaline level down. That's it. That's all we want to do. So I want you to go home. I want you to pay attention to your negative thoughts and let's do it. every single time you have a negative thought, I want you to do the deep breath. And I'm like, hey, man, science makes sense to me. I'll do it. Had my first negative thought walking out of the classroom. Oh, my God, this is stupid. It'll never work. But I did it. And that first day was a revelation, because when I actually listened, I was stunned at what my brain was saying to me. Most of it was about me. You're a disgrace. What's wrong with you? Nobody will love you. Nobody will care for you. You're so embarrassing to the family, Jill. Why do you have all this stuff? Why do you have pain? Are you being punished? Right? I mean, the psychology of trauma is fascinating to observe, but when you're in the middle of it, it's devastating. Okay, but every single time I did it, stop sign, deep breath, minimize thought. That first day I did it at least 100 times. Second day, I did it about 50 times. Third day, I did it about 20 times. You see what's happening? Look at that. We're bringing down the adrenaline, which is bringing down everything, including the negative thoughts. By day 5, I only had to do it once. 5 days later, I only had to do it once. And for the first time since 4th grade, I was not in fight or flight, because we got the adrenaline down. And that's what I do. I will be honest, I have one negative thought a day usually, and it's always about an earthquake. Don't ask me why. I do not know where this thought comes from. Is today the day we're going to have the big earthquake? In fact, we had one about 2 weeks ago. It was quite entertaining. I basically live almost on top of the fault of the 1906 earthquake. So I'm in earthquake central. Okay. If I have 2 negative thoughts in a row, that's 2 shots of adrenaline. No. I do my stop sign deep breath. It's very rare that I have 3. If I have 3 in a row, I double down. I do it 2 or 3 times. Man, I understand now that it's the negative thoughts pushing, scary thoughts, pushing adrenaline that's driving all of this. So I went through breast cancer. I never had a panic attack. I was doing it in the car on the way to the surgery. I was doing it as my parents were dying. You know? So, and Christine here said, yes, she had an abusive mother. Christina, I'm so sorry. I'm so sorry that you did not have a safe home. But what I want you to hear from me right now is that this says nothing about you as a person. You have done nothing wrong. You should carry no shame or blame for any of that. You are a victim like I was a victim. And today we get to release some of that. I no longer believe any of this was my fault at all. It wasn't. And I know that I'm a good person and a lovable person. It took decades to get there, but I'm there. I'm very, very there. And I want you to be there too. And of course, the challenge with trauma is that our brain remembers everything. And so it's very easy to get a smell or a sight or a sound that can bring it back. But that's when we have to say to ourselves, honey, that's just a ghost. That's a ghost of a memory. Let it go, move on, do something else. EMDR therapy, I found life-changing also. I definitely was very traumatized, losing my parents and then having a double mastectomy in less than a year. And I did some EMDR therapy to deal with that trauma, and it was very, very helpful. So let's go back here. Nancy says she's having SI joint pain and pain on the inside of my vagina. Any suggestions? Physical therapy for the SI joint, maybe wearing an SI belt if you don't have one. And on the inside of your vagina, we don't know what that is. That could be bacterial vaginosis. That could be estrogen atrophy, or that could be tight muscles. And so you've got to go to your gynecologist and have them check your vagina to see if anything funky is going on there. Debbie says, wow, it sounds like you're telling my story. Bad panic attacks. Yeah. Liz says, oh my God, Jill, I can relate to everything you've said about the overactive central nervous system. Yeah. And again, this is why bladder therapies are pointless for treating the underlying cause. A bladder therapy might ease some of the symptoms, but if you've got widespread pain and you've got a maladapted central nervous system, we got to work on the central nervous system. And until we can get that brain out of fight or flight, your entire body is going to be stunningly sensitive. All those nerves are going to be sensitive, whether it's in your skin or in your bladder or in your bowel, everywhere. We have got to bring it all down. So again, doing something like EMDR, which is very, very good, just practicing that deep breathing, getting out and walking every day, getting out in nature, things that give you a sense of safety. We have to feel safe. It's that sense of safety that our brain is looking for. Nancy says, me most of the time. Donna says, this sounds very familiar. Christine said she had her abusive mother. Johanna said, I had chronic complex regional pain syndrome in my right shoulder a couple of years ago. And after that, you started with the bladder issues. So Johanna, what that means, neuroinflammation, there's something called neurocrosstalk where nerves talk to each other. So if one nerve is inflamed, eventually a nerve near it can become inflamed, and then eventually a nerve near that can become inflamed. Another way of looking at it is that you've got nerves in our skin, and those nerves are connected to the spinal cord, and the spinal cord nerves are connected to the brain. And so that neuroinflammation can travel along those nerves, for lack of a better term. I'm sure there's a better explanation for that, but it happens. Donna says, home is her safe haven. It is for me too. But you know what? I'll tell you, there are times when I feel like home is my prison. I really would like to be out a lot more. But I built this life. Remember, I started the IC network when I was 33 years old. And I didn't know any of this. All I knew was that driving a car was painful, and I lost my job. I got fired from my job at the time because I was out because I was going to the doctor all the time. So and driving in a car was so incredibly painful for me. I mean, driving 10 miles is equivalent to driving 1,000 miles. The pain was so severe. So my life just got smaller and smaller and smaller, focused around my home. Now I can drive longer distance. I don't like to, but I can. I don't want to, but I can. My brain has gotten very, very used to living a quiet life at home. If I could do it all over again, oh my God, it would have been send this girl to therapy when she was in high school. But they didn't even know about trauma therapy back then as much. So if I really regret how anxiety turned me away from many, many wonderful opportunities. I do. Liz says, wow, I don't react to anything normally. I've been diagnosed as being hyper aware, anxious. I say no to invitations. I'm terrified of getting sick because of what happened when I was a little girl. My skin is so sensitive. You feel like you're rubbing it the wrong way, as if you were petting a cat or a dog in the wrong direction. I am most comfortable with being home alone. Girl, you're my twin. People would say I hibernated in the winter because they never saw me. Wow, you should do more shows about this. Dozens of catastrophic thoughts. It's just me. Thank you for talking about this. It's nice to know someone else has or has gone through this. Liz, there is hope, my friend. There is hope. You didn't cause any of this. None of this is your fault. But what you've got to, and that's the hard thing is, listen, the guy who hurt me is dead. At least I think he's dead. I mean, I was asked to do TV show. I mean, not TV shows, radio shows, talk about it. I wouldn't because I was afraid he'd find me again. And that was when I was in my 20s after he was already in jail. So, there is lingering kind of trauma that happens. But that said, we're safe now. You're safe now. I'm safe now. There's no reason for my brain to be in fight or flight at this very moment, and it's not. It's not in fight or flight, and I have not been in fight or flight. The last time I was, I don't know. I mean, was I in fight or flight when I was diagnosed with cancer? Yes. Was I in fight or flight as I watched my dad die? Yes, I was. Fight or flight is a normal response. The question is it persisting? And my answer is no, I do not allow it to persist. I do my deep breathing. I do my mindfulness. I do my EMDR. I go out and walk. I know the most important thing for me to do is to get outside and move my body. That always helps. Peggy said, it really works. It took me about a year, but my anxiety level is now lower than a year ago. I even taught my best friend, and it also worked for her. Yay! Rebecca said, I'm so happy there's more research being done on this condition. There's a ton of research happening. Christine said, you're amazing. Yes. Christine, another Christine said, EMDR therapy is wonderful. That's what I'm doing now for my childhood. Yes. Rebecca said, this is true. It's about balance of being home and going out. Yes. Yeah, like yesterday, I mean, I worked here for about 90 minutes on this diet guide link thing. And then I just I got to get up, and I just got up and I just did errands for like 4 hours and just had to get up and out and talk to people and see people and be normal again. My biggest problem is I just get tired of being alone. That's like my biggest challenge. And I'm seeing somebody, but I don't get to see him very often. And whenever I'm going out, and I miss Earl. Earl was my first love in junior college, and we drove everywhere. And he's my angel in my car with me. But I mean, for 2 years, I had such a wonderful time playing Jimmy Buffett and singing and driving up and down the beach and watching the sunset. Oh my God, that was my first love of my life. And he's gone now. He, it's a whole nother story. But I don't like having an empty seat next to me. That's the hardest part. Denise said, I've been in therapy and have learned breathing techniques, and it has helped immensely. Terrible childhood. Journaling has helped a lot to get me out of fight or flight. Yeah, I love journaling. Now, if I'm really struggling, I journal every morning and nighttime because I just want to get the stress out of my body. And that's the whole point kind of journaling, or at least the journaling that I was taught, is that I would write 3 pages longhand in a little notebook, not a regular book, just a little notebook like this, 3 pages longhand before I even got out of bed. Like as soon as I woke up, I'd get up and go to the bathroom, but I have to go back and lay in bed, get my pen. And my goal is just to empty out my all the stresses and worries before the day. I didn't want to carry these through the day. So I just sat there and I just wrote down whatever was bothering me, or what felt good. But usually it was whatever was bothering. What am I worried about? A doctor's appointment, dentist appointment, work, whatever. 3 pages longhand. And just releasing the stress and trauma was so good. And then, of course, you do the same thing at bedtime when you're laying in bed to go to sleep. You write it down again and you release it from your body so that it's not haunting you at night. And the rule is you don't read it again, because it's not about what you wrote. It's about releasing how you're feeling. And a lot of people just have a ceremonial burn once a week. Just tear it all out, throw it in the fireplace, watch it burn. because it's a symbolic release of this. It's a release of trauma. It's a release of fear. We don't want you to go back and linger on it. What you wrote is irrelevant. You can write whatever you want. It doesn't matter. You can write really bad things, really good things. You write, be honest about how you feel. I will tell you, I had moments when I had violent thoughts. I would, it's like if he ever goes to the death, gets a death sentence, I want to be there. That's a normal reaction to stress and trauma, especially when you've been hurt badly. So you just write it all out and then just don't reread it, just burn it once a week. And it's a symbolic letting it go. Just let it go. Because in the end, if you're living in anxiety, you're living in the past. The past is over. What we have to focus on is what can we do right now at this very moment to give ourself and our family comfort and joy. What can we do right now to feel better? And it's not about living in the past. It's about, okay, I can go take a drive. I can go out and walk. I can make some cookies. I made cinnamon rolls yesterday just to make the house smell good. And don't worry about the future. The future hasn't happened. One of the things you learn when you live with anxiety is that you have all these weird, if this happens, then I'm going to say this. If this happens, then I'm going to respond this way. And you get kind of lost in this fantasy that's not real at all. It's just your brain is catastrophizing. And then you realize you've just spent an hour worrying about something that hasn't even happened and will probably never happen. And so kind of getting out of your hand. And one of the things they say in mindfulness, your brain is like, if you've ever flown over a thunderstorm. I flew when I was 19 years old. I flew to New York. I went and worked at prep school for a summer. And so I flew by myself to New York and I flew myself back. So I had 4 plane flights across the country. And on one of them, it was a massive thunderstorm. I mean, it was the entire plains. And we were above it by, I don't know, 5,000, 10,000 feet, and looking out my window. And it was gorgeous. It was so pretty. And so you'd have clouds over there lighting up and clouds over here. It's just stunningly beautiful. For 2 hours, we watched this lightning. That's what your brain looks like when it's working hard. This area lights up, this area lights up, this area lights up, et cetera, et cetera. So one of the things that we do to kind of bring the entire central nervous system response down is to get your brain busy doing other things. And so if, for example, you start doing a Wordle or a puzzle, that is now occupying this part of your brain. So this part of your brain is not going to get caught up in all the anxiety and all the catastrophizing. So whether you're drawing, whether you're singing, dancing, walking, but doing mental activities. I love to paint, but I every night I do puzzles for like an hour and a half while I'm watching something on Netflix. And I just, and the other part too is getting older. You start walking into rooms and you forget why you've walked into the room. I've done that a bit. And so now I'm working on trying to keep my brain agile and healthy. Denise said, me too, and I've been in therapy and have learned breathing techniques. Right. And you did the journaling. Nancy said, look how many people you've helped. Your blessing. Oh, thank you, honey. Liz says, incredible show today. Yeah, baby. I kind of knew that. I thought this morning it was going to be a good show today. I'm really glad. Donna said, thank you for discussing this so openly. It helps to hear this. Christine said, cooking is my therapy. Another Christine says, when I'm stressed or in fight or flight, I do diamond painting. It's very relaxing. It's so hard to get over a really bad past. That's why I'm doing the EM DAR. I know, hun. I do paint by numbers, but I do really, really, really complex ones. I do adult, very advanced ones where I have got to use a magnifying glass to paint. I love doing those because I just get to turn off my left brain completely. And I just turn on some music or whatever. I'm listening to a lot of these stories on YouTube. I'm really loving them. Harry Potter, sleepy time stories, which I listen to at night. And now I've gotten into all these shifter 30-minute stories. They're quite entertaining. And I just listen to something and I just paint or cook. I haven't tried diamond painting yet. I actually had one diamond set, but I gave it to a very elderly neighbor. Nancy says, what do I think of antidepressants? I think that antidepressants absolutely have a place. What they do functionally is they calm nerves down. The challenge with antidepressants is the type of antidepressant. If it's an anticholinergic antidepressant like Elavil, amitriptyline, imipramine, nortriptyline, that is a problem because anticholinergic medications have been linked to dementia and cognitive decline. If you take it every day for 3 years, I think there's like a 50% increase in your risk of cognitive decline. And you would think that that would just be for older folks like me, but you know what? They found the same cognitive decline in somebody in their 20s when they did a study of patients in their 20s using antidepressants. Generally, if you're over the age of 60, they do not want you to be on any anticholinergic meds because we're trying to retain cognitive function. So that's, and the thing too is anticholinergic medications are all over the place. Antihistamines might have them. Even over-the-counter cough medicines and things might be anticholinergic. So there's a cumulative effect. So, and then we have to deal with the real side effects of antidepressants like Elavil. Weight gain. We call it the Elavil 20, that when you take an antidepressant, for some reason it turns on snacking and patients gain 20 pounds. I gained 20 pounds on Elavil in like 2 months. Once I stopped the medication, I lost the weight. But the bigger issue with Elavil is that it can change your heart conductivity and can give you tachycardia and arrhythmias. So if you can't take Sudafed because it makes your heart race, then the odds of you being able to take this class of medication drop tremendously. In my case, it activated a third node in my heart and messed up my heart badly. And so my heart rate, and my heart still does it 25 years later, every now and then. Normally your heart rate is beep, 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 because that's the SA node and the AV node firing. Beep, 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 beep. It turned on a third node for me. So my heart rate became beep, 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 beep. Or if two of them beat at the same time, it would be beep, beep, hard. Woo! It's awful. I wore a heart monitor for a month. Yikes. And now my heart's very prone to tachycardia. And now AFib. So I'm not a fan of antidepressants. If we're trying to control your frequency urgency, I would look instead at mirabegron or Myrbetriq. Mirabegron is a generic name. Brand name is Myrbetriq. That is a good medication that controls frequency urgency that is not an anticholinergic. All right, let me go here. You guys on YouTube, you've been so patient with me. I'm so sorry. Let me come back to your questions now. Crystal asked, do I know of any natural remedies to help stop smoking? Nicotine gum. You can do a nicotine gum. Although I was working with a patient who fell in love with nicotine gum, which was chewing 20 pieces a day. That was like 2 weeks ago. So you can't allow yourself to do that. The nicotine gum is a good transition, but the goal is to wean yourself off. You don't go up, you go down. Crystal said, what natural supplements are proven to help with overactive bladder? I'm asking because I can't take the medications for overactive bladder. I'm scared to do the Medtronic InterStim. Crystal, again, it's about what your phenotype is, what's causing that overactive bladder in the first place. So is the overactive bladder being caused because you're in estrogen atrophy and the nerves are now more exposed? So urine is irritating the nerves, which is causing your frequency urgency. You would be looking at a chondroitin-based supplement like Bladder Builder, Bladder Rest, Sister Protect, or Cystomen. Those are all in our shop at the IC Network. I would not be doing Eucora or any of the cranberry supplements. They make no sense. This is not bacterial. The vast majority of us, this is not bacterial. There's no reason for you to do any of those supplements. Christine said, when I had my rectocele surgery, my surgeon was great, except for why the vaginal estradiol was important. You had to research that yourself. Yes. And Crystal says, how do you control your central nervous system? With what we call mind-body medicine and working with a therapist if you're a trauma patient. April says, Jill, would a gentle chin strap, such as a CPAP, help the thing? I found it helped my jaw settle down when I was trying to lay down. Not all chin straps are alike. Beware that. You know what, hon? I've tried a couple and they didn't work, but I never considered a CPAP chin strap. That's a really interesting idea. Yeah, I mean, like I'm always pushing in right here. I'm just popping it back into place. And it's not that the jaw is not completely dislocating. It's just something is popping out of place and I have to push it back up into place. Crystal said, what about the pumpkin supplements? The pumpkin supplements have only been found helpful for chronic prostatitis. I'm not aware of any research showing that they're helpful for like estrogen atrophy, anything at all like that. I mean, I was at the American Urology Association conference where they presented the very first pumpkin research study showing success for chronic prostatitis. But I am not aware of, although, you know what? Let's look real quick. Let me look real quick. I couldn't read a lot. I mean, yeah, understand, I was pretty out of it for about 2 years here. So between caring for my parents as they died and then cancer, I just didn't have a lot of time to research stuff. I was just trying to get through the day. So hold on, pumpkin. Not a single study showing pumpkins helpful for interstitial cystitis. Let's do bladder pain syndrome. Nope. And just out of curiosity, let's see if anybody's published any studies showing aloe is helpful for interstitial cystitis. Nope. Not a single published study showing aloe is helpful for interstitial cystitis. That's why, it's another reason why I don't recommend the aloe supplements. No, honey. Well, let me look. Let's look at pumpkin overact. I'm at the National Library of Medicine. Hold on a sec. 6 studies. Let's see. Okay, profiling curcubita seed extract. And that's a study of European varietals. Pointless. All right. Outcomes of a complementary and alternative medicine based on vitamins, herbal products as first-line treatment for overactive bladder. All right. Let's see what they say. What did they do here? So this is a study where they gave patients a supplement that had vitamin C, vitamin D, pumpkin, capsicum, and Polygonum cuspidatum, and the amino acid L-glutamine. They say it may be a useful medication for first-line treatment for uncomplicated overactive bladder. Okay, here's a study from 2019. 12-week study of women with overactive bladder who took a supplement called Granufink Femina, an herbal combination of seed oil from pumpkin, sumac bark, and hop cone extract. And that was 7 years ago. I just don't see a big role for it for pumpkin. I just don't. Nancy said, you've done a fantastic job. You went through so much. Yeah. Oh, I've come to realize that I'm a lot stronger than I actually that I thought I was when I was younger, but I'm also very stubborn. If somebody says no, I'm going to try to find a way to do it anyway. I mean, I pitched the idea for a website on IC back in 1993, and people laughed at me and said it was stupid, but I did it anyway. All right, so we have been going on now for about 2.5 hours. Hold on a sec. Let me see. Was there something else that I wanted to... There was something else. Okay. You would think I would make a list of all the things that I want to talk about, but I don't. I mean, I usually don't. But there was one other. Let me find it. Okay. What? Early in life, stressful events induce chronic visceral pain and changes in bladder function. So that's the whole trauma thing. But hold on. So, study exploring the molecular link between obstructive sleep apnea and IC. It's what they call a machine learning study. I do not understand machine learning studies. Oh, yeah. Here is yet another paper that's trying to justify the use of Elmeron. This came out of Korea. They were trying to show that using Elmeron, there was a benefit to using Elmeron for chronic pain and lower UTI symptom or urinary tract symptoms. They followed 204 patients from October 2006 to May of 2021. They say that patients got better over time, and they usually became stable at month 3. They say patients usually arrive at a plateau at 3 months. And of course, they make absolutely no comment about the eye damage and the bowel damage. So, you know, you have to understand economic forces are at play. There are people who want to sell Elmeron because they make money, you know, and that's where profits get in the way of safety, in my opinion. I have a bumper sticker on my car that says, "The billionaires are not your friend." I think that products that cause harm, like Elmeron, shouldn't be used anymore. I just don't. But there are other people who make money from it, so they want to justify that it works, so they're going to potentially fund studies or whatever. I don't know if this group got any money to do this. I have no idea. But what I do know is that they're not talking about these risks. Oh, and, it didn't print. Oh, here it is. Really in that research study of the 86-year-old who'd been on it for 26 years, who were on massive retinal atrophy, I printed out one of the pictures in the paper. So this is over time. So this was at the first visit, and you can see just a little bit of white here. That's abnormal. This is at a second visit, and now you can very clearly see that the surface of the retina is changing, and we're starting to see kind of widespread damage. And then here you can see that the white has spread throughout the area. I mean, that it's much bigger. But this is kind of a 3-dimensional picture of the retina. So this is at the first visit. Things look fairly normal. We got a little bit of retinal thinning here. And then we see bigger changes here, and then bigger changes here, I think. Progressive structural changes in pentosan-associated maculopathy documented by optical coherence tomography. Cirrus OCT reveals that between year 1 and year 4, zones of retinal atrophy with outer retinal thinning associated progressive retinal thinning. By year 11, the macular lesions have coalesced, and there is severe disorganization of retinal thinning with loss of retinal laminations and disruption and thinnings of the outer nuclear, outer plexiform, and photoreceptor layers extending beyond the macula. That's what this medication can do. Not to everybody, but to a pretty significant chunk of patients, that can happen. All right, and now was there one other thing over here? Hold on. Another paper with Monty Lucas showing success to mediate mast cells. So, I know I'm just kind of randomly talking about this stuff. In our magazine, The IC Optimist, I go into it in depth. And so if you want, so we do our magazine 3 or 4 times a year. It's called The IC Optimist. And it is a collection of feature stories, investigative stories, self-help tips, food stories. I mean, literally whatever is happening. So I'm writing the winter one right now. Hopefully I'll be done this week with our winter one. And that's where I think we do our best work is with our magazine and also with our video series. If you haven't watched the IC 101 Masterclass, please watch it. I still have 5 episodes to put up. I just haven't had time to put them up. They're all on managing flares. So, but if you like these meetings, if you find these meetings helpful, please think about becoming a member and getting our magazine, because that's what pays the bills so I can do it. And I will tell you, times are very hard right now for everybody. And so we have a $25 membership. You can read everything online. You get like 7 or 8 past magazines, 3 or 4 future magazines. It's a deal. It's a deal. Well, all right, my friends. I have not had a question in a couple of minutes now. So let me do a last call for questions. I'm happy to put on a video. I'm happy to take your questions. I'm doing okay, but if we're done, and that's okay. I will go heat up some chicken noodle soup. Well, I think I'll go take another walk, my second walk. Now that my pneumonia is better, I can go walk again, but I'm going slow because the super flu was rough and it put me into AFib and pneumonia. So I can't go walk the 2 or 3 miles that I used to walk. I have to go. I'm doing like a half a mile right now just to kind of work my way up again. And I've gained 5 pounds in the last 6 weeks because I couldn't exercise. And I was eating carbs. So I'm not happy about that. So I am very anxious to get myself moving again. All right. So last call for questions. Last call for questions. All right. I think we're done. I'm going to say goodbye to YouTube. Bye, you guys. I'll see you next week. Knock on wood. Knock on wood.